Lakeland Currents is sponsored by Nisswa Tax Service. Nisswa Tax Service offers tax preparation for individuals and businesses. Across from City Hall in Nisswa and on the web at nisswatax.com.
Hello again, everyone, and welcome to Lakeland Currents. We are entering our 7th year. Very happy and proud to be doing that. And through all 7 years, our underwriter has been Nisswa Tax Service, and we're very thankful to those folks for being with us, putting up with all the things we put up with, bears and fish and all the things over all the years. I appreciate that very much. For our first show of the fall, we're going to be talking about, I think, two very important topics, and that is two of the major health issues facing Americans today. And with us, we have two experts who are from the Cuyuna Medical Center. I'm not sure if it is a Cuyuna Regional Medical Center, sorry. To my immediate right is Dr. Paul Severson, and to his right is Dr. Howard McAllister. And both of these gentlemen have been in the Cuyuna hospital system, they were just telling me, for almost 30 years. So they've seen tremendous growth. And I haven't been over to the Crosby area for a long time myself, but I know that is considered one of the hospitals really making some pretty impressive waves in the medical community for its growth and for the innovation that's occurring over there. So it's very nice to have both of you on the show today.
Thanks, Ray.
And tell us what we're going to talk about.
Today, we are going to talk about the two most important or most common diseases, and perhaps the one that's the biggest impact is obesity. Obesity is an epidemic in our country. We're going to talk about that, and we're going to talk about its relationship to reflux, gastroesophageal reflux disease.
Now, before we get into the technical parts of that, maybe you could just tell us a little bit about what's happening at your center, because I know you're growing. You said you have 20 surgeons. Could you just give us a little background about the growth and what's happening over in your organization?
Sure. Dr. McAllister?
I think that what we have done years ago is we tried to identify some of the important trends, not only in the disease processes that were affecting Americans, but also in some of the technology development, some surgical techniques. And so as we identified those, we began developing some of the skills ourselves to be able to not only do them, but also teach them. And so teaching has been an important component of where we have gone in all that time. So we have made an effort to make sure that we are, not just us, but also the surgeons that have come after us that we have hired as we started. As we were talking earlier, Dr. Severson and I were basically the first two surgeons at that institution in this modern era, and I think that a lot of the growth that has taken place has revolved around modern techniques, modern technology, and the ability to use it effectively to address those problems.
For viewers who might not know where Crosby Ironton is, it's about 14 miles northeast of Brainerd.
Yep.
And when you started there, roughly how many employees did you have in your hospital system clinic?
Well, we had, I was the first, I would have to say, modern board certified surgeon coming up, introducing some new techniques at that time in 1984. And I joined 5 family physicians. It was a very small hospital, lazy little town. We had a few hundred employees total between the clinic and the hospital at that time. But the growth took place after the revolution in surgery took place, which was in 1989. Dr. McAllister had joined me in 1987 after the older surgeon retired. And what happened was it was an invention that took place that changed everything in surgery. And that was the ability to take the gallbladder out through little tiny wounds on television using cameras and small instruments inserted through little tubes in the abdomen called trocars. And that's what changed everything. We took a great interest in this new technology, and Dr. McAllister and I became pretty good at it. And what happened was doctors started to come from all over. As soon as we started to learn advanced techniques beyond the gallbladder, like reflux disease, we started to treat in the early 90s. About 70 surgeons came to train with us. So we developed an educational institute. Then we had to hire more surgeons. And today we've grown from just the two of us up to 20 surgeons.
I was watching an old Roy Rogers movie the other day.
Loved Roy Rogers.
I did too. The thing that stands out on some of those old movies is everybody's thin. I mean, there really aren't very many obese people, and I'm sure there's always been obese people. But when you look at the characters and the subplots and the people who aren't even stars, just about everybody looks like they got the men look like they got 30-inch waists, and the women not much different. And if you compare that to some of our movies today, you just see this trend that we've developed over the last 30 or 40 years of getting heavy.
Well, and those have been studied. As we track the average weight of Americans over the last 20 years, we see that currently almost 2/3 of Americans, well over 60%, are considered in the overweight or the obese category, a body mass index greater than 30, which is significant. And we lead the world in that. There are no other countries that have a higher percentage of its population that is obese.
And that, I'm sure, is affecting a lot of the things you see when people come to the clinic. If they're obese, I mean, the high blood pressure and all the related things. When you do your surgery and you do your work with people, you're also, I'm suspecting, having to try to change lifestyles and attitudes about how they live. Would that be a fair statement?
Yeah. What happens with obesity when people get morbidly obese? Morbid means deadly, and that's the truth. People die younger, significantly younger, sometimes a decade or more younger than they normally would had they been able to maintain a normal weight. But it causes other problems, other comorbidities, we call them. Diabetes is going to be the next big #1 killer if this trend just continues, and so far nothing seems to be stopping it. High blood pressure, you mentioned, high cholesterol, reflux is part of this whole syndrome that occurs, and then of course obstructive sleep apnea. We're hearing about people getting machines to have to sleep now at night.
Is there a correlation between that and obesity?
Oh, absolutely. And all of these problems can be corrected when we do surgery to get people back to a normal body weight.
It's an interesting concept to identify. It isn't the obesity that is specifically dangerous. It's the diseases that the obesity contributes to. So we see that as people become more and more obese, as a higher percentage of the population becomes obese, we see a higher percentage of the population develops diabetes, develops heart disease, develops sleep apnea. And the thing that we know, that we have seen, that's been shown over and over again in the literature and all the medical studies that we deal with, show that as we resolve the obesity, we can resolve a lot of those comorbidities as well. And that's significant, has a tremendous impact, not only from a psychological standpoint, returning a patient to a productive role in society, but also in terms of making them live longer, and not just live longer, but actually have a better life for that period of time as well. The number of times that patients tell me, for example, that older patients will come in that they enjoy now being able to play on the ground with their grandchildren. This is a significant contribution to their life and to their lifestyle. What Dr. Severson said is absolutely correct. The surgery that we do doesn't make people become thin. What it does is it helps them to change their lifestyle. It's the lifestyle change that addresses a lot of those issues and resolves the obesity itself.
What is your determination of when a person maybe needs this or qualifies for surgery for weight loss? How do you determine that with a patient?
That's a great question, because it's very specific in terms of what an insurance company will allow. You just can't decide yourself, I want to have obesity surgery. It's actually figured on something called the body mass index, which is easy for people to figure out. You can go right online, look up BMI calculator, and you can determine what your body mass index is. It's simply, all you need to know is your height and your weight, and you plug it in the formula, it tells you what it is. If your body mass index is over 35, that's called severe obesity, 35 to 40. You can get surgery if it meets that level. If it's over 40, you don't even need one of the comorbidity diseases along with it. That alone, even if you're healthy and just that weight, we know that you're going to have all these problems, and insurance companies know that, and then they'll pay for that surgery.
Now, when people go through this surgery, do you have statistics of how successful it is? I mean, do you have a lot of people who repeat? I mean, it has something to do with shrinking the size of their stomach, obviously.
It's part of our level 1 center.
I think that there are a number of factors, and in fact, we're only now beginning to understand a lot of the factors. We used to think that it was just a smaller stomach, restricting the amount of food that they could take in, enforcing behavioral changes, but we know that it's far more complex than that. There are a variety of biochemical changes that take place as well that physicians around the country are only now beginning to understand.
Really?
So, for example, they began to notice this when they would see that we would do these operations on people and would find out that their diabetes would resolve itself within a week after the operation, not dependent on changes in their dietary intake, not dependent on the weight loss.
Wow.
And so as they began to look at that, they found that there were so many different changes in the body regulatory hormones that control appetite, that control satiety, or the full feeling you get when you eat, that they began to look at that and say, whoa, there's a lot more going on here than just this mechanical restriction.
Wow. So when a person's gone through this process, then do they spend a certain amount of time in your facility learning how to cope with the changes they have to make?
They have to prepare for you can't just come in and get a surgery. You have to meet all the members of our bariatric team. And at MIMUS, the Minnesota Institute for Minimally Invasive Surgery, we call it MIMUS, it's easier to say. We have a big team. It's a level 1 center, which is the only place in central Minnesota that has that designation. And that means that if you're a senior, you can go to a level 1 center and you can have your surgery done there. They won't, but see, Medicare will not pay for any other lower levels. You have to go to them. When you meet the people at our center, they're not just surgeons. We're just one spoke in the wheel. You meet our bariatric psychologist, you meet the bariatric nutritionist, and you meet the bariatric nurse coordinators. We have a team of people that prepare the patients, and it might take 3 to 6 months to really understand what you're getting yourself into with this before you actually could qualify for one of the 2 main surgeries that are offered.
As surgeries go, is this a very painful, long, recuperative period surgery?
It used to be in the old days. I think that it was a big operation. It was an incision. A surgeon and assistant surgeon had to make an incision big enough for them to get all 4 hands in. The laparoscopic revolution, which is an outgrowth of the things that Dr. Sievers and I have been trying to perfect at our institution over the last 25 years, has made a huge difference in that, because we can now do that same operation and do that in an hour to 2 hours and have the patient be able to leave the hospital within 1 or 2 days afterwards and resume relatively normal activities, except for eating, within a week to 10 days afterwards. So it's a very gratifying thing to be able to turn that major operation into something that they can recover from so quickly.
That must have been a little frightening when you did your first surgery, wasn't it?
The first one that we did took us 6 hours, simply because the techniques were not well defined, because the tools were not well defined, and because we were inexperienced. And the patients have done well. We've been very pleased with that.
That patient's still here?
Oh yeah.
We were fortunate
Yeah.
because it did take us longer, and we didn't have. Now we have it. Seems like it's almost perfection. We just.
Well, that's understandable.
You take an hour and you do this complex operation, and everybody knows what they're doing. We have other surgeons now. We have 2 younger partners who are excellent bariatric surgeons. We have a bariatric fellowship now, the only one in our state, where young surgeons come to train for a whole year to learn these advanced techniques. And it's when we look back and think, we're fortunate because everybody lived. We've never had a fatality, from the thousands of operations that we've performed at this point in time. And I got to admit, in the early days, we weren't as good as we are now.
And that's understandable. You're pioneering some new techniques, obviously.
We have been fortunate, and it has been a great learning experience. And we learn from our patients, we learn from our partners, we learn from our colleagues around the country. It's been a great experience over all these years, because it makes a tremendous contribution to the health and the welfare of our neighbors and people from all around the upper Midwest. As one of the very few level 1 advanced bariatric centers, we get patients literally from the 5-state northern region that come everywhere, not only to have their operations done primarily, but also to have things repaired if things have been done elsewhere. So we get referrals from other institutions as well, from all over the area.
You mentioned there's a connection to overweight and sleep apnea. What percentage of patients usually are overweight that do have sleep apnea? Is it?
Well, we have to test everybody who comes in. They take a little quick quiz to see if they might have some of the symptoms from that, even if they don't think they have it. And then if they fail some of the questions on that, then we get a sleep apnea test.
One of the key questions is to ask their wife how this, whether or not they snore, and that's
or
so
stop
that's
breathing at night.
Mm-hmm.
Yeah. So
Wives are
we
usually on
screen
that.
and then we test, and if they indeed have it, they wear a CPAP machine. We call it the Darth Vader mask, and they have to wear that at night in order to breathe properly and try to help their heart and lungs. When we do the surgery, there's an excess of 90% of people are cured, from that, from getting their weight loss surgery. Yeah, so
Wow,
they
that's
usually
impressive.
can shed the machines and return to a quiet. Their spouses love it.
I bet.
It decreases the and this is a potentially deadly problem. It leads to potentially deadly cardiovascular diseases as well as acute danger. Can cause cardiac dysrhythmias in the middle of the night. It's one of those things that is not well understood in the general public, but scares a lot of physicians, primary care physicians in particular. And a lot of people will find that part of their screening questions from their primary care physician is, do you snore at night?
Now, I know that the GERD issue and the acid reflux issue is one of your specialties now at your hospital. Could you just talk a little bit about what this is and what you're doing there?
Yeah, there's a strong relationship, obviously, between obesity, because as you gain weight in your waistline, for every inch that you grow, there's more pressure against the stomach pushing up into your chest. So we see more hiatal hernias, we see more reflux of acid and gastric juices coming up into the esophagus, and sometimes coming up all the way into the mouth, causing all kinds of problems like coughing and sore throat, a burning tongue, sour taste in the mouth, hoarseness, even symptoms that don't even seem to be directly related to reflux.
A lot of people will see on television the television commercials that show the fire in the belly, and this is what heartburn is, and so they think of reflux disease in terms of heartburn, but in reality only about 40% of people who have significant and dangerous reflux disease actually have heartburn. A lot of them come in without symptoms or symptoms that may not seem related. Coughing is one of them, as Dr. Severson mentioned, hoarseness in the morning, those types of things. People with these chronic coughs might go to their ear, nose, and throat doctor thinking it's sinus drainage. A lot of our referrals come from ENT doctors who have worked them up for sinus drainage and found out that it was actually coming up from the stomach as well. So some of the traditional ideas as to what constitutes reflux disease have been changing a lot, and it's been one of our challenges to stay on top of that.
One of my friends was diagnosed with cancer in the throat, and he's been at the Mayo Clinic, and they said that was probably a result of acid reflux.
Yes, that's finally become knowledge now in the medical literature. It's been published for several years that GERD, gastroesophageal reflux disease, is a precancerous condition, because if it goes on long enough, the damage that takes place to the esophagus causes another condition called Barrett's esophagus, named after a doctor that first named it. Barrett's esophagus has abnormal lining in the lower esophagus, and that is what eventually changes into esophagus cancer. And esophagus cancer right now is increasing more than any other cancer in our nation. It too is becoming epidemic, and it's directly related to the rising epidemic of reflux.
Unfortunately, one of the key treatments, one of the key medical treatments for reflux disease has been some of these over-the-counter drugs like omeprazole and some of these other things. You can buy them in convenience stores, and what they do is they decrease the amount of acid output by the stomach. And although conventional wisdom held for years that this would actually decrease somebody's risk of esophageal cancer, we know that that's not true anymore, and that it really has no effect. What it does is it stops the symptoms of reflux disease, but it does not stop the risk of esophageal cancer. And it's one of the reasons, it's been proposed as one of the reasons why esophageal cancer rates have been increasing over the last 20 years. It parallels the increasing use of those particular medications. So we see that as more and more people take those, the rates of esophageal cancer continue to increase.
So is an average thin person less likely than to have this issue?
There's no question that obesity contributes to that. It's kind of the same concept. If you step on a tube of toothpaste, it's going to come squirting out. And the same thing is true. The more abdominal contents that you put inside the abdominal cavity, the more pressure is going to be on the stomach, and the more reflux there's actually going to be. So there's a tremendous relationship between obesity, but it certainly is not the only relationship, because the fundamental problem is abnormal relaxation or weakness of the valve at the lower end of the esophagus. Normally, this will keep stomach contents from getting back into the esophagus. It's an important concept because the stomach can protect itself against those digestive enzymes and acids. The esophagus has a different kind of lining, and it can't.
So when a patient comes into your clinic and they want to see if this is an issue, how do you diagnose this? What do you do?
Well, we have a GI lab at MIMUS that all of us surgeons are in charge of and that we run. And we have numerous testing modalities to be able to evaluate the esophagus. We usually start with scoping the patient. And that's done commonly in almost all hospitals are able to have a doctor who can pass a scope and find out whether there's any Barrett's esophagus or any complications of the disease. You can get strictures from scarring. You can get this Barrett's that we mentioned. You can eventually even develop cancer. What people get a lot of times early on is inflammation and then ulcers forming in the lower esophagus. That's treated effectively with medicines. But here's the problem. There's 44 million people in the United States taking these medicines. It's estimated that there's 7 million people of those 44 that are taking medicines. Their doctors have been giving them medicines in full doses, and they're still not happy. They're having breakthrough symptoms. They're still wanting more help, and that's where we come in as surgeons. We have 2 procedures that are available, the old laparoscopic Nissen fundoplication, and now we're offering a brand new operation called the Lynx magnetic sphincter augmentation implant.
Which is a mouthful, but basically what this is a flexible ring at the lower end of the esophagus that helps to reinforce or augment that one-way valve between the esophagus and the stomach.
So is that permanently installed?
Well, it can be removed, but yes, the intent would be that it would be permanent, and the idea that it would then permanently prevent the ability to reflux stomach contents back into the esophagus. There are a tremendous number of people who fit into that category. It's a relatively straightforward operation with very low complication rate, very low side effect rate, and has been very successful in our practice and around the world where it's been implemented. It's not readily available in a lot of places. In fact, there's only a small handful of physicians in Minnesota that are qualified or certified by the company to be able to do that procedure.
So if you're having this acid reflux issue, is it like heartburn, or how does it feel to most people?
Some people get chest pain. Some people get neck pain. Some people have a chronic cough, hoarseness. A variety of symptoms can manifest themselves, and so it just goes beyond the traditional heartburn. So it requires that your primary care physician and your gastroenterologist and all the other people that you end up seeing for this are aware of what all those other symptoms might be. Unfortunately, we found that that's not necessarily the case, and so we've embarked as part of our whole process at MIMUS on an educational process as well to try to educate other physicians as well as patients what this is all about.
So if somebody keeps having symptoms and they're taking over-the-counter medications, they really should have this checked out.
Yeah,
this
absolutely.
is going on
Well,
for a long period.
it's been recommended that if you've been treated with medications for 10 years or more, that you should speak to your doctor about this and consider getting a screening endoscopy where you get scoped and a doctor looks in there to see if you have any complications of the disease. We don't want to miss cases of Barrett's. We don't want to have the rising number of esophageal cancer patients be one of our patients. So that's a concern. And if they can't get help from the medicines, definitely should seek a consultation regarding this.
And of course, everyone's different. I understand that. But if they were to develop cancer in that area, is that a slow process, or is that something that can happen quite quickly?
Well, unfortunately, it's a relatively silent area, and one of the things that we'll see is patients will come in and they'll say that they're having difficulty swallowing. And the problem with the cancers of the lower end of the esophagus is that there's such a rich network of blood vessels and lymphatic tissue that in many cases, maybe in most cases, by the time this cancer of the esophagus is discovered, it has already spread too far to be effectively treated. And so a lot of the operations to do this are these tremendously big, radical operations that have a tremendously high morbidity and not a very good success rate. So we have come to the conclusion that the idea is to try to diagnose this sooner rather than later. One of the things that's important is to identify the patients who are at risk, and this requires not just surgeons and gastroenterologists, but also primary care doctors. And somebody who comes in and says, geez, for when I was a kid, I had a tremendous amount of heartburn every time I drink a beer, and then it just went away. I stopped having it. That's a warning sign. And those are the patients that we need to look at. And if they have a tendency towards Barrett's esophagus, we screen them every 1 year, 2 years, or 3 years, depending on their risk profile, to make sure we go in with a scope at that particular interval to make sure that they are not progressing towards esophageal cancer.
And I should add that we do have, the good news is for someone who has Barrett's, we have the tools to ablate or destroy the Barrett's and get rid of it. And with the techniques that we currently employ, we've had them for almost 10 years now, we can restore that esophagus and almost eliminate the risk of a cancer of the esophagus. So that's the good news. And we can do that endoscopically on a same-day surgery. Just like the LINX procedure now, which we believe is going to become big in the United States once it gets beyond the trials which we're currently involved with. There's 3 places in our state that are currently offering the LINX on a limited basis because it's not yet approved by insurance companies, so we have to kind of fight case by case for it. But when that comes, that may be the next first-line therapy surgically for those people who can't get help with medicines.
We're out of time already. Fascinating topics, it really is. How do people get a hold of your facility if they want some help?
They can call the Minnesota Institute for Minimally Invasive Surgery. That number is 218-546-4343. And there are people. And there's a website, the MIMIS, M-I-M-I-S, Minnesota Institute for Minimally Invasive Surgery. The information is also available there.
Doctors, thank you very much for appearing on our show. Very good information. Appreciate it.
Thank you, Ray.
You've been watching Lakeland Currents, where we're talking about what you're talking about. I'm Ray Gildow. So long until next time.